So welcome everybody to talking about the drug supply in 2024. I'm Alicia Gonzalez. We will introduce ourselves in just a minute here. This is one of our favorite topics to talk about each year. Like, what is the landscape that we're dealing with right now when it comes to substance use, and what do we think is going to happen? We made our first predictions last year. We'll talk about a little bit of those, and we have so much material to get into, so we're going to dive right in. In case you haven't heard of us, California Bridge is funded by the Department for Healthcare Services here in California. We are a nonprofit organization, and none of our speakers today have any financial disclosures to offer. However, we sometimes use brand names when we talk, and that's not because anybody's paying us. It's simply because our patients use those brand names. So if we say, Narcan instead of naloxone, there's no preferential treatment being given. Please just understand that that's what our patients say, and so we tend to say that. All right. I am Alicia Gonzalez. Like I said, I am the clinical training director for the California Bridge program. I'm an emergency medicine doctor out here in California, and I am joined by two of my very, very favorite experts in this field that, like, when I want to know, finger on the pulse, what is happening out there in the world when it comes to substance use and treatment, this is who I call Charles and Rebecca. I'll let them each introduce themselves first. Charles.
Hello, everybody. My name is Charles Hawthorne. I use they, them pronouns. Some of you might know me as being a former employee of California Bridge, having worked with a lot of y'all doing our racial equity and harm reduction work. I left California Bridge back in July, and now I'm doing some more of my own consulting work, and still being able to be engaged with this team is really wonderful. So I'm super excited to talk a little bit more about what I've seen happening in the harm reduction and drug use world out here in California.
Awesome. I will find any excuse to bring you back into the California Bridge fold. So, okay, Rebecca.
Hi, I'm Rebecca Trotzky. I'm a family medicine doctor that's had the honor and privilege to work with a lot of our emergency medicine team in Los Angeles County. I work at the largest public hospital here, and I now have the great honor and privilege of running our brand new addiction and community medicine service. So that's been really fun. I've been working with California Bridge since its founding, which, gosh, I feel old. It's got to be, what, 7, 8 years now? Something like this.
Amazing. Yeah, and I do consider
Yes.
you one of the clinicians that I go to for like practical information. I think you're so insightful in that, and I'm sure it will come through. So I mentioned that last year we had a very similar conversation about, the drug landscape in 2023. And I will start by saying that at that time, the hot topic on everybody's mind was xylazine. If you don't know what that is, go back and watch the webinar from last year. But Rebecca, what happened with xylazine? Were we right? Was that something to be worried about or to be watching for? What ended up happening there?
Yeah, we still see a little bit of xylazine, and we've always seen this constant, like, little trickle. Like, I have maybe 2, 3 patients last year amongst maybe 1,000. We have a couple different sources of data. One is the forensics. So when law enforcement confiscates drugs, they do test it, and they're like, what is this white powder? And they're saying maybe 1 out of a couple hundreds is testing positive for xylazine. The other source is our coroner reports, and then our clinical testing that we would do as a routine part of care. All of those have come back negative. We send out our xylazine test when we have some clinical suspicion, negative. So, we haven't yet seen it penetrate like it has in the East Coast. We're still keeping our radars up.
All right. So does that mean, would you say in general, like, we were wrong about that, or was there anything we were right about in that conversation?
I think the important piece here is that our unregulated drug supply is always going to have adulterants and contamination, and we have to think upstream, and Charles is going to talk about this lovely model of thought, and we also need to think about at every possible moment what's coming, what's changing, and having a pulse in our community about what's going on, both with the people who use drugs and then people who are testing drugs.
Yeah. So maybe the main take home was xylazine, we could just call it X. It starts with an X. Drug X could be anything, and that we learned we have to be on the lookout for whatever is going to happen. It's not a regulated system. There could be anything laced in your drug, or you could think you're buying one thing and not get that thing at all. There's no quality control there, which, I'm glad that you mentioned Charles's name, because Charles, one of the things you are best at and you're so good about is harm reduction. Is this idea that we got to know what is the right counseling for our patients? What's the right conversation? What does it look like for a person who uses drugs to do their due diligence to minimize harm from doing those drugs? So last year, we talked a little bit about harm reduction in general. Where are we at now? Where is that movement? What are some updates from the things we talked about last year?
For sure. So around naloxone, last year we were really talking about it kind of being like the CPR, the AED of 2023. That's still very much true. It's something where we're seeing it roll out all across schools, across different types of community programs, and we're really trying to make sure that we're getting as much of it into the community and that people are learning how to use it. Some big developments that have happened, it's now been approved for over-the-counter use. For those of y'all who are maybe more involved with some of the more grassroots harm reduction work, Remedy Alliance for the People, which is a nonprofit based here in the Bay Area, ran by a really powerful harm reductionist named Eliza Wheeler, is actually rolling out their own generic brand of naloxone that they are distributing to organizations across California and across the country. That's making it much lower cost, which is incredible. But California is still continuing to fund distribution, making it very free, very, very easy for patients to access it. You should not be needing to purchase naloxone in California at all, especially if you're on this call. And awareness is happening in a really big way.
Yeah.
When it comes to fentanyl test strips, they've become a bit better, a bit more accurate, easier to find, easier to get. What we know is that those test strips are always going to have some margin of error that usually actually relies a bit on the testing protocols. Not all of us are actually trained in how to do lab testing, especially lay people. And so there's still room for those to not always be totally accurate.
Yeah.
But they are starting to roll out more testing available. Strips available in hospitals across the country. There was
Yeah,
an
well, and actually that's a good point. That happened last year, right? It became a law, at least in California, that you have to be able to test for fentanyl for your patients. So if anybody missed that, we have a memo from an all facilities letter that went out last year. So make sure your hospitals has that capability for you, which is great.
Yes, and Aiden just dropped that all facilities letter in the chat. So make sure you look at that, send it to your administrators if they are making it challenging for you. And it shows that people are continuing to really take fentanyl seriously as they should. We know we're continuing to see some both pretty high profile overdoses as well as an increase in overdoses among everybody across the state. And so staying vigilant around that and being able to talk about that is huge.
Yeah. So I mean, I think naloxone. We talked about that last year. It's still a thing. If you're not in California, there is a really neat movement happening across the nation to make naloxone distribution reimbursable. There are states that have been trying to pass like laws that mandate that, which is awesome. So we are seeing efforts, nationwide to increase naloxone distribution. Even though it's over the counter, it's not free over the counter, right? Patients have to pay for it. So we still think it's really important to put it in their hands. So that's a good update. What about 2024? Like what are some things that are new, maybe we didn't talk about last year, that are a changing or developing conversation in the harm reduction space?
Yeah, I mean, naloxone, I think that that's something interesting to think about. Naloxone is like a bit of a gateway for people to harm reduction, but it's not the only thing at all. There's a lot of different layers that we kind of have to keep moving on in order to actually get to a place where we're reducing drug-related risk for everyone within this country. And that means starting to be able to talk about some of these new marketing tactics that come from people who are selling drugs. I think that it's important to recognize that drug sales are a business and people who sell drugs are there to make money. And when we are operating in a place of capitalism where people are striving to feed themselves, just as it's harder for everybody else to make money in this country, it's getting challenging for all people who are selling all types of things. And one of the things they're realizing is people are really concerned about contamination. They're really concerned about people who are purchasing drugs are concerned about getting drugs that are quality. So there's people who are selling drugs who may be labeling it as more clean or versus a typical or a standard option. And this is kind of where that piece of that business and supply chain starts to meet those fears of community with their own marketing tactic. And while there are strategies and ways and conversations that we can encourage our patients to have with the people who they purchase substances from, just calling something clean doesn't make it clean. Just calling something pure or natural or organic, just like we know in the grocery store, doesn't actually make it that.
Wait, so you're saying right now the people selling drugs have caught on to the fear and are now telling patients like, oh, do you want this regular blah blah or this one, which is the clean version? It doesn't have fentanyl. Like they're pretending that they have any idea.
Yeah, I mean, yeah. And I think that the important thing to kind of note is that like people who sell drugs are often also people who use drugs, who are also in community with people who use drugs. So these are not always completely different categories. They're not the sad, sick, lonely people who use drugs and then the big, mean, evil dealers. That's not actually a reality that exists. This is a community. And in this community, people are having these conversations. And what that might look like sometimes is people saying, hey, I purchased this heroin from this person. It is much higher quality. Maybe I've tried it myself. Maybe I've seen the effects of it. Maybe people have given me this report, and this is what I can say about it, versus this is maybe a lower cost option that might be more contaminated, that might have some of these other things. And it's not always coming from a place of deception. And marketing is, can we call marketing deception? That's a much longer conversation for our college members. But I think that the important thing to note is, as consumers, how are we empowering our patients to be able to ask the questions and go through some steps and processes to be able to make these decisions for themselves, which might include things like wet testing. When you first start using a substance, start with a very, very, very little bit. Don't just jump 2 feet in. That might mean making sure you're re-upping before you are getting dope sick, because that's going to mean that you're able to have a little bit more patience with that first hit. You'll be able to take a little bit more time and lean into it, and actually assess how you're feeling. And then there's also like different, but I think largely the point that I wanted people to take home is that these tactics are marketing tactics. These are not actually lab designations or descriptors of what is actually the things that people are purchasing. And that doesn't mean we need to operate from a place of deception, but it does mean that we need to operate from a place of critique and being able to evaluate what is it that we're putting in the body in the absence of a regulated drug supply.
I think it's amazing when I hear you talking, because it can be really uncomfortable for a healthcare professional to have a really blunt conversation about drug use with patients, but even being able to tell them things like, Rebecca put this in the chat, but like start low, go slow. Like, look, if you're going to use drugs, you don't have to use the whole bag at one time. Like, start low. You don't know what's in that bag, no matter what somebody sells you. Just be careful. Things we've talked about many times. Have naloxone around. Don't use alone. If you are going to use alone, we love talking about the Never Use Alone hotline. It's a free hotline patients can use anonymously, so that if they do overdose, someone will send EMS response to them. Like, these techniques are important for us to get more comfortable talking about, which I think is really important. You also mentioned something, patients are often intentionally trying to use something, but one thing I noticed popping up more and more are questions about using multiple substances at once, which I think a lot of us refer to as polysubstance use. And so that is one thing I wanted to bring up. We know that, yeah, opioids are killing a lot of people, and I love the work that we've done in the opioid space. But methamphetamines are also everywhere, and alcohol is everywhere, and we have all these other drugs that we are thinking about, and there's a lot of fear in treatment. Like, can I still start buprenorphine if somebody's using meth or using cocaine or whatever, or doesn't know what they're using, is using some random thing they got from their neighbor? Rebecca, can you talk to me a little bit about that? Like, what are some trends that we're seeing emerge in like the polysubstance use space, or things that clinicians should be aware of?
Thanks. First, I will have to get on my bandstand about the phrase polysubstance is like my most irritating fingernails across the blackboard, because I don't know what somebody means. So I'll get a healthcare report of this is a polysubstance user. I'm like, does that mean tobacco and alcohol? Does that mean fentanyl and heroin? Like, what do you mean by that? So it is important to really understand what mix somebody is trying to intentionally use, and then what mix might be unintended that we can also help create some messaging for safety around. And to normalize the concept that we every day use all kinds of substances to modulate how we're feeling, right? Like, drink too much Starbucks in the day, take extra melatonin at night so you can sleep, right? That's something that everybody does. So often when somebody is reporting that they're using stimulants, or we uncover that, I almost invariably ask, like, when you get overamped, when you get overstimulated, how are you coming down from that? How are you balancing that out? And people will report, oh yeah, alcohol, or sometimes that's when I use a little bit of fentanyl. And so maybe initially they're identifying themselves or reporting to us as, I just use methamphetamines. But when you dig a little bit deeper and talk about how you're feeling and how you're using your substances, and maybe it's not an everyday thing, maybe it's like, once a week I'm feeling this way and I'm using this other substance to balance that out. It is important to uncover, because even if it's not a use pattern that we would, put as our first problem list in our medical note as opioid use disorder. When somebody is also using opioids and a bunch of other drugs, we have that elegant technology of buprenorphine to offer somebody so that they can help feel a little bit more level. And we see that people, when they're on buprenorphine, when they have opioid use disorder, they're often using a little bit less stimulants, because those are the two balance points, and people want to feel, a good level point for them. So, both, it's important for us to clarify what somebody needs by polysubstance, recognize that's the normative thing. People are often like kind of tweaking how we're feeling every day, all the time. Like, oh, I'm feeling down, I want to go for a run. So it's not pathological, it's a normal part of human experience.
Well, and what about for treatment? Like, we talk so much about buprenorphine for opioids. And then I think one of the most common questions you get from clinicians, or comments I will say, is like, yeah, that's great, bup is great, but all my patients use meth, or all my patients drink alcohol. Looking ahead at the work that we're doing with Bridge, what are some other areas where there are options that we want to make sure people know about?
Yeah, for sure. Both of the medication, or both of the stimulants and the alcohol, have medications and behavioral interventions that help people use less drugs. And as Charles was saying, we have important messages to help people use drugs more safely, no matter what drugs those are. Even if it's something we've never heard of, we know how to help people use drugs more safely. Start low, go slow, have naloxone on hand, use with a friend, stagger your use so you can kind of help each other out. And know where to go if you have run into a problem. So those are messages regardless of what you're using, even if it's intentionally polysubstance or, quote, unintentionally polysubstance and adulterated drugs. We do know that, again, uncovering buprenorphine treatable options is really important. So if somebody's using opioids, even if it's not that frequently, even if it's not problem number one, make sure we offer that treatment. And then also there is medication, like we're using a lot of mirtazapine, we're using naltrexone to treat stimulant use. And there is medication for alcohol. Again, we're using a lot of naltrexone and long-acting injectable naltrexone as well, which is Vivitrol. So there are treatments, and it's important to be positive about that.
Yeah. And if you're somebody who's never heard of those before, I do want to mention that California Bridge has protocols for each of these. Aiden's dropping them in the chat, but in case you're watching this recorded later, if you go to the California Bridge website under the resources page, we have a full guide for treating alcohol use disorder, a full guide for stimulant use disorder. These are really important conversations to figure out, which of the many meds that we have, we do have options, which ones are the right ones for your patient, by identifying which substances. I love that comment, Rebecca, because polysubstance, like tobacco and alcohol, like, what are you talking about? Figure out what they're using and why, and which ones, can you give medication for to mitigate some of those risks. We did talk a little bit about stimulants just now, which is maybe one of the most common things that comes up. I do want to throw out a random question, because I feel like Matthew Perry's death, the Friends guy, like brought this in vogue. Like, ketamine, we know we love this in the ER setting as doctors. Like, we use ketamine medically for so many reasons. Like, what is happening? Why is ketamine everywhere? Why are there clinics that offer ketamine? Like, can you tell me a little bit about that?
Yeah, ketamine has really never gone away from use for, euphoric reasons, or, people wanting to use it for fun. It's been in the club scene for a long time. And it's also, as you mentioned, very therapeutic, and more evidence for medical kind of regulated safe use for both chronic pain, for maybe treatment-resistant depression. There's a bunch of reasons that we're using it, both in the emergency care setting, in the hospital setting, and then more and more in the outpatient setting. That's very different than, somebody using a high amount of ketamine alone in a bathtub, right? That is a setup for danger. And we want to, again, help people in all these settings be able to use their drugs more safely if they choose to use their drugs. So again, when we're having these messages of don't use alone, there's reasons that we want to make sure that people stay safe. And, these ketamine, quote, overdoses are examples of those reasons.
Yeah, awesome. Charles, one thing that you often talk to me about that I find really helpful is this idea that whenever we talk about substance use, I feel like everyone is assuming that we're talking about people who like overdosed on accident and are like victims of this system. And I think you're so good at always keeping us in check. Like, remember that people are doing this on purpose. Like, not all substance use is addiction. Not all drug use is negative. And I was wondering if, kind of in light of what Rebecca was just talking about with ketamine, how people are trying to find therapeutic purposes for it. Like, what comments do you have about that in general? This idea of like, addiction versus just recreational use, or what's happening in the world right now with that?
I think it's really complicated. I think that our world is quite tough right now and very challenging. And as more and more people are navigating really challenging financial situations, really challenging social situations, a world that is feeling like a fucking dumpster fire, to be frank, more people are looking at to substances as a way to be able to cope, as a way to be able to navigate. Even when we talk about specifically the effects of ketamine in a recreational sense, allowing people to let go, allowing people to not feel a lot of the emotional pain, allowing the stopping of like your mind constantly racing. These are things that people are seeking out, like feelings people are seeking out that maybe they could, if in a less chaotic world, they'd be able to find more naturally. But alas, here we are in 2024, and ketamine is doing the job much more easier, much cheaper than anything else they could find. And so it can be social, it can be recreational, it can be medicinal for people. I mean, I don't know about y'all, but I get advertisements on my Instagram every day about trying ketamine therapy. So like there's a way that there's also this destigmatization that's happening that isn't necessarily always being coupled with a conversation around safety and around what does it mean to intentionally engage in drug use? What does it mean to engage in ritual drug use? What does it mean to engage in substance use in a way that works for you? And I think that at the end of the day, the drug is just a thing. It's like you can't call it good or bad. It is just a thing that people do. And I don't even really call the way people use things good or bad. I don't really love their term at all just because it's not helpful. But it's important that we're bringing a certain open-mindedness to the conversation, that we're not just immediately jumping to this place of judgment that often comes from our own fears as medical providers or our own fears as parents, our own fears as caretakers, our own internal fears about what we've been taught about drug use, and that we're able to like hold a conversation that starts with something of like what do you find helpful about this? Why do you want to use this? What does it bring to your life as opposed to just telling people all the bad things? People know all the bad things already. And we're going to continue to see as we do more research on different substances, mushrooms, more things on ketamine, on cannabis. I mean, like all these substances are things that people have used for like much, much longer than we've had a medical system. Maybe not ketamine, but like mushrooms and other and marijuana and tobacco and alcohol.
Yeah.
Like these are things that people have been using since kind of the beginning of human existence.
Yeah,
Um,
we self-medicated before we had medical medications, right? That's a real thing. Yeah.
and even to think about the concept of self-medication, you know, at a place where you have people, thousands of hundreds of thousands of people across this country, millions of people across this country who don't have access to regular medical care, we have to stop demonizing the concept of self-medication and self-medical care because it's not accessible. And so, like, yeah, if it was cheap and easy to get a psychiatrist or to access a therapist, we could be having one conversation. But in lieu of that, going to see a therapist is $150 in the Bay Area, and a gram of ketamine you can get for $80. So
Yeah. And actually, you said the word demonizing. I want to bring up something controversial. Woo! We talked about something controversial last year, so I want to dive in. I want to talk about Portland a little bit because I think, right, so last year we talked a little bit about how we weren't trying to make a case for legalizing drugs. I want to be very clear. California Bridge does have a formal statement about decriminalization of drugs, which is not the same thing as legalization of drugs. I just want to throw that out there for anybody on the call who didn't know that. You can see in the chat our formal stance on decriminalization. Again, different conversation, but we did talk a little bit last year, and we have already today mentioned that as long as the drug supply is illicit, there is no such thing as being able to regulate it or quality check it, et cetera. That's real. That's just a reality. And we aren't trying to say whether it should or shouldn't be legal. However, Portland, right, quote unquote, legalizes drugs. And I feel like I have not seen a single positive thing about that in the news, on, social media. People are talking about this in a really negative way. And I was hoping that I always really appreciate your insights into stuff like that. And I was hoping you could talk to me a little bit about what's your response to that? How do you address it when somebody brings up like, well, look at Portland. All this work you're doing is wrong. Look how bad, what a nightmare experiment that was. What would you say to somebody who brings up that
I would
time?
say, having worked in San Francisco for 5, 6 years, it is completely unsurprising. I think that there is this really complicated piece of what does it mean to have this goal and this theory around what does it mean to do radical work and change the way that our policies work, and how does that execution come to bank? And the thing is, a lot of times when we talk about execution, we're talking about multi-departmental, multifunctional, cross having decision making things that are really complicated. And anybody who's ever worked in government or even worked on a group project knows that is not simple. And there's always going to be things that fall through the cracks. And so even as we're kind of moving through it, like we're still, Portland's navigating the same thing everybody else is navigating. Drug contamination. There's an unregulated drug supply. Prohibition is making the drugs getting to the city still dangerous. And the goal was originally to be able to make the community safer, to be able to support access to harm reduction. And then the access that is being created is not really getting the attention, but what is getting the attention and what's being hyper fixated on is the fact that we're no longer engaging in these same punitive strategies that are putting people in jail, that aren't actually stopping them from using drugs, that aren't actually preventing any sort of deaths or harm. All it's doing is disappearing people so that folks don't have to look at them. And that's really the challenge people are coming to terms with, is when we start talking about not putting people in jail, not just pushing people away or not allowing them to just die, we're forced to actually look at ourselves as a community and see the world that we've built. And that's really uncomfortable for a lot of people.
Yeah. So I mean, what I hear you saying is it wasn't necessarily the quote legalization of it. It was the execution of the idea, and maybe not maybe definitively without enough attention on the support, on the access to harm reduction, on the access to treatment, like that wasn't emphasized.
Yeah. And I think whenever it comes to these types of things, any sort of these like progressive policies, there's a way that people are looking for us to undo 400 years of oppression and hundreds of years of policies in one election cycle. And that's just not how life works.
Yeah. I'm actually looking really quickly. We have somebody who works in Portland who dropped a comment in the chat. I'm going to read it. It says, I work in Portland and Measure 110 was implemented before we had the infrastructure for low barrier recovery. Throw in COVID and the execution of the program. And that was all kind of delayed about 2 years, the treatment part of it. And so she says, I think we just need more time to prove efficacy. I thank you for saying that. That's supporting exactly what Charles is saying. Like they rolled it out, and then COVID, of course, delayed everything. And so the infrastructure for the piece to support that, we are seeing it now since it's decriminalized in our face in a way that people aren't comfortable looking at. And so we do need to give it more time. I just really appreciate everybody for saying all of that. Rebecca, I know that when you and I talk about this, one of the things you always tell me is like, yes, that's what we say about Portland, but we seem to just turn our blind eye to the fact that like San Francisco and Los Angeles and other cities have plenty of a mess of drug use happening. And we just pretend like Portland's the only demon. I mean, what's at the heart of all of this? Like, what are your comments about this situation?
Yeah, my feeling is that when we have narratives that reify existing stigmas and existing cultural beliefs, even when those cultural beliefs are false, we use those to make our beliefs more concrete, and we become more intractable on them. So there is a false belief about drug use in our communities that's aligned with racism, classism, sexism, and all the other things. And it's challenging to really have a pause, like we've all seen, science not connecting with lawmaking, and say, hey, is the changes that were made in Portland really that different than, and the results that different than what happened in these other cities and in southern cities? And we know access to healthcare is the #1 thing that helps people stay alive. And so is that the piece that's different between these cities? Is it, is it a law? Is it all these other complicated institutions that play into community safety? And when we have a law that's changed, we want to like hang our hats on, oh, it's because of this, it's because of that, when we know it's so broad and so challenging. So, and Charles was mentioning too, it's like all of these policies have had intergenerational levels of challenges that we have to make up for, right? We have to understand that it's not a simple quick fix this generation and then everything's equal. We have families that have been burdened by inequities for generations, for 500 years. So it's not going to be a quick fix in this generation.
Yeah, I think a summary of what I'm hearing you both say is what's coming in 2024, what happened in 23 that's continuing to happen is like a way more in our face conversation about it. And that's a good thing, actually. I love that. Like we're having a much more open conversation. And I do know we're at 10:30. Charles has a hard stop. There were 2 questions in the chat that I want to bring up. So Rebecca and I will stay for a few minutes, but Charles, thank you for being here. I always appreciate your insight and your wisdom. And I love bringing you back to Bridge anytime I can. So thank you. And for those of you who have to go at 10:30 hard, also remember that everything we referenced, all of our resources are available to you, as will a recording of this webinar once we're done with it. But I do want to just also say we have the California Bridge Academy. If you want to get CME, if you're a clinician, or if you're a navigator, or if you're a nurse, we have all this like free CME for you. Feel free to join us at the California Bridge Academy and watch some of those lectures. But there is a private question that was sent to me in the chat, actually, that's about a basic thing about buprenorphine. And I just want to put, I kind of like, Rebecca, I'll let you talk about this. Like, what do you make of it that we're still, here we are 5 years into our work, and people, I mean, I understand the fear of wanting to ask a basic bupe question in public, but what does that tell you? The fact that somebody is still asking us some basics about bupe, what does that mean for us in 2024 when we're like talking about law changes and decriminalization and all of this, and then yet somebody's like, what's the right dosing for bupe, and is it okay to use it if someone drinks alcohol? Like, what does that tell us? Where are we at?
Yeah, we still have to remember our basic 101 bupe is so important, and buprenorphine access at the pharmacy, at the medical centers, and in our community is so important. So to just recall whatever else somebody else is doing, if you have unregulated opioid use, I recommend prescribing buprenorphine for that person. Even if that person isn't saying that they want to change their use patterns, having buprenorphine available along with naloxone allows them to make decisions in the future to pick up that medication and to start that medication in a way that will save their life. We know that is true. The dosing that we're using in Los Angeles right now, and it's coming out more and more in evidence-based literature, that when we have fentanyl in our communities, which we all do, that 24 milligram a day dosing is important and better than 16 milligrams a day. And starting people at that 24 milligram dosing when they're in withdrawal. So there's lots of different ways to get buprenorphine on board, but usually by day 3 in that exchange, people should be at that pretty high dose, or normal dose is, I will say, 24 milligrams sublingual daily is what we're aiming for.
Yeah, we also updated, if you haven't seen it, anybody on the call, our quick start guide got an update. We don't talk about 8 milligram dosing anymore. Yes, there are going to be a small subset of patients that only need 8 milligrams, just like there are some patients that only need 5 milligrams of amlodipine for their blood pressure, but it's not most people. The vast majority of people need better support. And so these, what we used to call high doses of bupe, are now just regular doses of bupe. And in fact, 2, 4, 8, even 16 for some patients would be considered very low dosing and inappropriately low dosing, like, fairy dust sprinkles on a problem. So take out the look at please look at our new quick start guide. Think about these normal doses of 16 and 24 as being appropriate for most patient. And what I will also say is there's some new data that came out that showed that the number of patients needed to treat, right? We always talk about how small that number is. The number of patients needed to treat to keep someone in treatment is lower at higher doses. So if you do 8 milligrams and then you do 16 or 24, the patient's getting 24, you have to treat fewer people at 24 milligrams to retain them in treatment. They will stay in treatment longer and better, which is life-saving. So don't be afraid of those. And again, I want to pitch the California Bridge Academy. If you need any of the basics, we have all of that there for you. If you can't remember any of this, email us, info@bridgetotreatment.org, and we will send you the link, no problem. But I want to turn this into a formal call to action, that if you have to make one goal in 2024, maybe, one thing per quarter, what can you do to advance basic buprenorphine access in your clinical setting? Because that is still work that we are doing. Even though we've moved really far along in our content and our support, we're all still working on the basics. We're all still trying to increase that access for all of our patients. So don't ignore those basics. We talked about so many things. I want to briefly just recap. So we have touched thousands and thousands of lives here at Bridge through our substance use navigators, through our clinicians. We've started so many people on buprenorphine. We've counseled them to other medications for alcohol use, et cetera, got them into ongoing care. This is critical work that is not done yet. And so somebody actually asked privately in the chat, like, what is next for California Bridge? Is your funding over? What's happening? And the answer is, listen, I am actually really proud here in California. I mean, no offense to all the other states, you got to have pride where you are. So I love my state and the investment that our state legislature has put into combating this, opioid and other drug epidemic, that they're really helping fund our efforts to save lives here. And so I don't see that going away. I have confidence in our legislature to keep supporting us and maybe helping our primary care colleagues, to be able to manage bupe better outpatient. And how do we make sure that we have uniformity in our dosing across the state? those kinds of things. I'm really proud of the work we've done here, and we're not going anywhere. So for any of you in any state that's relying on us, we're still here. Feel free to reach out anytime. And thank you so much for being here. We know that this work saves lives, and it also saves the healthcare system money, and it also decreases ED utilization when we don't need it. All these things that we know translate to better access to care and easier throughput in our systems. The answer is medication for addiction treatment, decreased stigma, harm reduction, and low barrier access to medication. So thank you all for being here. I love the comments. They make me so excited. Like someone says, we're friggin' saving lives. Yes, we are. Thank you for being a part of that. And thank you for having this sometimes challenging conversation with us. Reach out if you need anything, and have a great 2024. Thanks. And thank you, Rebecca, for being here. Thanks, everybody.